So, as you've just heard, I'm here to tell you about the work we're doing, and I'll pick up from that comment about being massively qualified. I have spent a very long time in policy roles, both in the state and Commonwealth, in both health and social policy. And whilst I'm not an academic, one of the abiding frustrations I had as a bureaucrat in senior roles, working with ministers, trying to develop policies that governments wanted or that governments had been encouraged to implement or develop, was the lack of translated evidence in the Australian context. We are not a country with a history of civic leadership at the intellectual level, I suppose. We have lots and lots and lots of what we call NGOs. And in the way that these things come about, they are largely single-issue organisations. And we form lots of platforms for them to work collaboratively. So we have alliances of all kinds of things, including the Chronic Illness Alliance. And all those organisations, in their own way, are focused on their perceived mission, usually to support members and represent the interests of members. And they all do good work, but they don't actually often immediately provide useful material for policy making. And academics don't either. They might be doing fantastic research, but when you're in the policy making business and you try and talk to academics, it's like somebody talking German and the other one talking Swahili. And a lot of the time, as a senior bureaucrat, I would try and bring academics into a task force or a working group or a project consultancy or something to help identify the best evidence that was relevant to the question, whatever the question was. And quite often, our best available resources were overseas, in the UK and the USA in particular. And there were two organisations, one the King's Fund in the UK, which has been going for a very long time, and the Commonwealth Fund in the USA, which has also been going for a very long time. It is a different sort of beast. And they were the sources for me and my teams and the work I was doing, most commonly, of translated policy information. The evidence says this is how you put it into play, whether you're talking primary care level, acute care level, or some other part of the health system. So when Victoria University, which is a university in the West, approached me to talk about, I'm going to skip that one, it's unhelpful, approached me to be part of a new idea, which was a think tank focused on health and education policy, supported by a philanthropist. I thought it was a long overdue, very good idea, and I was pleased to be able to help get it up. There's a backstory to why we're now a health policy think tank, and I'm not going to take up precious time to tell you about that. It's just one of those things that goes in the territory of universities in Australia. We don't have well-endowed universities other than the 8 known group of 8. Most other universities have been brought into being over the last 50 years and they're not well-resourced. This one is probably the least well-resourced of any university, which also makes it the most appropriate for what we're doing. But it also means that it doesn't do things well much of the time. So we are now a health policy think tank, solely supported by the university. The mandate we were given is there. I won't go into that. But the particular focus that we have and were asked to have by the university was a focus on chronic disease, the big health issue of the 21st century, as we all know. Also a focus on socioeconomic disadvantage and cultural diversity and their interaction with chronic disease. And that's a really powerful issue because just listening to what I heard of Alison's, all of those campaigns are fantastic and effective, and we know that going all the way back to tobacco campaigns, road safety campaigns, social media, whatever its version is in the contemporary world. is effective. We are compliant in many ways to the messages we hear, but there's a pocket or a strata of society that is the hardest to get to, and it's the lowest socioeconomic levels. And campaigns have to be tailored and different strategies have to be put in place. And that's the group that is looming largest in the preventable chronic disease space in Australia, along with other things. And so our focus has been on that socio-economic picture as well as this picture, which is, and I won't repeat it, you know all this. This is a snapshot in time in 2013 of how Australia compared to like countries, relatively like countries. And as you can see on alcohol, we're up at the top. On tobacco, we were then better than most, and we're better again. We're down to closer to 12%. But on obesity, we were very fast catching up to the top of the league list. So you know all that from Alison and your own work. As I have said to you about struggling to find pick-upable evidence for policy making in the Australian context, I've been around long enough to have been party to much of this. Ever since the Ottawa Charter, as a signatory to the World Health Organisation and a participant in its leadership, Australia's gone along with the campaign to do better about health. The big divide we have is that we still have health systems focused on illness treatment. We have an understanding, rather dim in Australia, that health policy needs to think about maintaining health, not allowing ill health that is preventable. So we've done a whole heap of things, which as I said, I've been party to an awful lot of them. And they've, in most cases, been substantial reports. In some cases, they've even been organisations or formal agreements. That was the most sort of exciting period of time under the Rudd government, when we had formal agreements to do things about prevention and we had an agency. That got shut down, as we all know. And now we have a chronic conditions framework, which is good, but it's words. There's nothing behind it at this point. And while that's been happening, all those activities, and I'd love to have the money that was spent on them, this is what's happened in 2 areas of chronic disease. That's just 2. They haven't had any, well, if they've had an effect, heaven knows what we were going to be like. But they clearly haven't had enough effect. So when we were asked to develop this think tank with a focus on chronic disease, socioeconomic disadvantage, etc., one of the things I did know from my many years of experience was that we don't need any more evidence. We're drowning in it. It's everywhere, and everyone uses it, and we all use it to good effect. What we need is impact on policy. We commissioned some consultants to go off and talk to people around the country about where we could fit in a crowded landscape. How could we, all those people have something to do with chronic disease. How could we complement rather than compete? The last thing we need is another NGO or another thing saying the same thing differently. And that is one of the biggest issues in policy making, which is why the Commonwealth Fund, the King's Fund are so influential in their countries. And I wanted to be part of something that could be influential here, is that when you're in a minister's team as a bureaucrat or as a chief of staff, as I was for a while, what you get is a lot of well-intentioned people and very well-informed and resourced people coming to you and saying, you need to do this about obesity, you need to do that about something else. And they all say similar things differently. And there's no translation unit in government anymore. There used to be. We used to have policy coordination units. We don't now. So ministers are faced with, how do I sort this out? Who do I go with? What's telling me truth, whatever truth is? What's telling me fact? And what's more important from a policymaker's perspective is what's feasible, affordable, implementable. And can be done in 3 years, given our electoral cycle. So we don't tailor our messages terribly well to that at all. So we set out to work out where we fitted. And the first thing we did was a policy paper, which was an exploration of the issues in Australia. I'm not going to give you the detail of that, it would take too much time. We launched that in 2014 and it was called Chronic Disease in Australia, the Case for Change. And it basically mapped what I've just talked about. All the good things that have been done, all of the lack of effect of some of those things, the plethora of evidence, the lack of implementation of that evidence in an effective way. And it looked at some of the better examples internationally of how that happens. So Finland comes up very firmly in the horizon as one of the shining stars. So do now some South American countries. So by contrast to our peer groups, we're sometimes worse than others that have less resources than we do. The Case for Change went out as a discussion document and we invited people to come and talk to us about it and to help us fit ourselves into the landscape. And 80 odd people brought themselves, we had no funding for that, our funding is minimal, to a discussion in Melbourne. And this group came together as a loose national collaboration around the work we then undertook. With them we produced a blueprint for change, which has a quite simple strategic framework in which we decided we would all work collaboratively, and we're the engine, we're the facilitating group. So as you can see, there's quite a lot of people there, and others have come on board that we don't have up on that slide. This is the strategic framework with the vision that we articulated. This has been agreed by that collaboration. And we brought people back together when we launched the blueprint to talk about, so what? Here's a good blueprint. It's great for everyone to use, but how do we actually make it live? How do we change that trajectory against all that activity that I've already shown you? That discussion led to an agreement that what we needed, having agreed on those principles, which are really very important, that the first thing we should do to try and change the policy debate in Australia is to develop measurement. There's been a quotation going back, I think, a couple of, well, probably 1,000 years, but its most recent iteration was Margaret Chan, the former Director General of the World Health Organization, who said in her incoming speech, when she was appointed, what gets measured gets done. And under her watch, the WHO developed the non-communicable diseases targets and goals for 2025, which as a signatory country, Australia is committed to in principle. But we've not done anything towards developing targets for Australia to improve chronic disease. So we've done it. We've done it for government, we've done it with the group we worked with. They agreed that we should have an Australian set of targets relative to the WHO targets. And through 2015, we had an amazing process. As a bureaucrat, I've had an awful lot of people working in ministerial advisory councils or committees or task forces with great goodwill, but this was extraordinary. This was in people's own time. 7 working groups came together. We took the 6 target areas of the WHO non-communicable diseases action plan and added mental health because it is highly related to other chronic diseases, and those people with a persistent mental illness have a 14 to 70 year lifespan gap compared to their peers without. And the premature mortality cause is not mental illness, it's chronic disease, preventable chronic disease. So we put the 7 together. We did a very intense piece of work, which I won't bore you with because it's a technical document and you've really got to like reading data to deal with it, but it is our credibility. It is the evidence. And we moved then to translate it to policy information. That's the global action plan that we worked from. which has the world targets, and together as a group, once the indicators were done, the targets and indicators were done, we moved to a policy translation product of that information, which is Australia's Health Tracker. It's now 18 months old. I've got a couple of copies of it, but it's on the website. It's deliberately colourful, it's deliberately simple. The working groups worked on with us and came up with the target or targets that they thought were most significant against the agreed risk factors. So this is just giving you a snapshot. We used a traffic light system. Red means you're trending in the wrong direction. Green means you're trending in the right direction. Where there is nothing, it's because Australia doesn't have enough data. For a well-resourced country, we're pretty poor on our health surveillance data. So we've made an issue out of that. This just gives you a snapshot again. You know the obesity stuff, you probably know the cholesterol stuff. Physical inactivity is pretty alarming, even though we know it. To look at a figure that tells you that in 2011-12, 44.5% of adults reported physical activity below national standards. So you know that's conservative. Our experts set an Australian target of 40% by 2025. And we asked for stretch targets. So they recognise that this is going to be a big one to try and shift. Cholesterol, that's not good. 1 in 3 of eligible adults in the age and weight range for cholesterol have high cholesterol. Again, the target is, it's a good target. It's still down to getting the risk in our population down to a quarter of the population. It's not exciting, is it? And blood pressure and so on. These are just examples. The big thing about this work was that I hope I can get this to work, but anyway, I'll talk to it first. All of this was done to influence policy, not to tell anybody who already knows what they already know, but to translate it. That's our goal. Hence the simplicity and the colour. And I've been reassured that we've got on track with this when I've walked into ministers' offices or into senior officials' offices and I can see the colour poking out from the shelf. It's not gone to the back of the room, it's not gone out into the bin, it's on the shelf. That's effective. I know that's effective. Things stayed on my shelf, it was because I was going to look at them. They weren't things I was going to look at, they went out to somebody else to file. So for me, that's a really significant indicator. It's also a resource for everybody else. We have used the media to get the message out, as we all do, of course. It's an important tool with which to inform the public. And we've had remarkable take-up stuff. We're a very tiny team with 3 full-time people, 3 part-time people, 3 contractors. And we just put this out without any full-time media support. I'll see if I can make this work. I'm not the technical expert. We'll see. Oh, don't do that to me. If I can't make it work, I can't make it work, I'll have to talk to it. Yeah. Come on, where are you? Yeah. Oh, I think I've lost it. No, I've lost it. Anyway, what I was going to try and show you was a remarkable video clip done by SBS, which we knew nothing about, and one of us happened to see it that night when they went home. They didn't even contact us. So this is data that is working for people that don't need an expert to translate it. That's a goal. What we have behind Health Tracker is a website where all the data that we've used, which is national data, it comes from AIHW, it comes from the Australian Health Survey and the ABS census data. We have national data that is regular collections, so none of this is expensive. We're just curating what's already in the public domain. That website can be accessed by anybody, and it gives you this data where we have it, because you can't get some data down to local area levels. We've got it by LGA, we've got it by primary health network catchment, we've got it by state and territory boundary. What SBS did, as with the ABC, is they went and got the data that they wanted to get, and they ran a video clip, which was just extraordinary. I'm deeply disappointed. I don't know how to make it work. Is anybody with technical expertise around here? My clever young people can make it work, but I can't. It's what's that? No, it's a clip on that.
Yeah, but it was a website.
Yeah.
It was a website.
All right. Okay.
And the only
It's embedded, I think.
Highlight it and see if.
No, don't think so. Anyway, I'll talk to it. It is extraordinarily funny. It's a spoof. I started watching it and thought, oh dear, this is dumbing it down. No, what they did was ham it up. And it is extraordinary, and it will get through to people who don't normally hear the messages. So we're starting to get some chinks in, inroads to a broader audience. The data speaks for itself, but having launched Tracker and launched Tracker by area, the working groups work on with us because that's what we all want to do. And we're now in this space of taking the work forward into, so what can governments and others do about it? And the intention is to drive support for things like Live Lighter, to make this priority business rather than plea business. Everyone's in the plea business. Please fund this, please fund that. We need to change that. This needs to be health priority business. So the working groups came back, and on the basis of the targets that we agreed were the priority ones, and for some reason I seem to have lost the slide, might be too late. They took out of the 30-odd priority targets that we developed these as the most important to get Australia on track by 2025. It's a reduction in the overall mortality at the same level as WHO has set it. It's a 20% reduction in the harmful use of alcohol, 30% reduction in average salt intake, 60% reduction in smoking rates for adults with mental illness, where there is the highest rate of smoking. Halt the rise in diabetes, halt the rise in new diabetes. Halt the rise in obesity, halt the rise in new diabetes. Halve the employment gap for people with mental illness. So you can see the way it's spread beyond what people think as health to health-inducing influences. It is a change on the term social determinants of health, and I guess this is my personal professional ambition. The term social determinants of health is both too narrow and too defeating. It was very good when it was invented, but they're actually the social determinants of disadvantage, and that's in work, employment, it's in health, it's in education, it's in housing, it's in a whole heap of things. So they're too narrow in how they work to policy, and they're too defeating. And I've had a minister say, well, what can I do about them? They're social, they're determined. What can we do about them? This is the way of the world. And remember, every minister, every decision maker is usually not an expert in this stuff. They're an expert in what they do. The content has to come to them in ways they can deal with, and we don't do that very well. So we went from those targets to working on what policy actions will bring about change. And I'm now completely out of sequence with this, so I'll just keep talking. The working group came together and produced Getting Australia's Health on Track, which we launched last year. I'll see if I can find it because it's easier. There it is. And against those 10 priority areas for change, the 10 targets, and this was a really interesting exercise because most of the people working with us are from universities or national organisations like the Heart Foundation, Stroke Foundation, etc. Most of them are really good at what they do. But when we got them together for this piece of work, and we did all this by teleconference because they're all around Australia, and I'm the bully, I said, no, you can have one ask. You've got a treasurer in the lift, you've got 3 minutes. She says, I'm really interested in what you do, but there's only one thing I can get into the budget. What is it? Tell me quick. Because that's often the way things work. So they struggled. They really struggled to get down to one that would make the first step, be the first step towards major change. We gave in to the tobacco group. They insisted on 2, and correctly, because there are such disparities. We do need to keep the population level coming down, so they set a target of 5%, whereas the current national target for government is 10%. But, as they insisted, the health disparities in smoking levels are appalling. And amongst people with mental illness, we have smoking rates still at the 1980s level for the general population. So we're abandoning a group of the most vulnerable to cancer. And we're going to make that really clear with this work. So they got 2. We added in the one that I just mentioned, monitor the health of all, the lack of good data. And we have a paper just about to be released asking for a recurrent Australian health survey every decade, with the next one to be 2021. So this was released last year. It is very, again, simple and colourful. I'm just picking on the one that's talking about the health levy, the sugar tax. I don't use the word sugar tax. It's the first thing to scare away treasuries and to give power to the lobbyists against it. So we're using the term health levy. I actually want to go beyond that and start talking about harm minimisation, because that's what governments understand, and it can help them with the stakeholders they have to navigate. So let's look at the health levy. We identified what the ask is. We summarised the problem. We showed the scorecard from the health tracker. We talked about the evidence for the intervention we're arguing for, health levy. And then we just summarised the priority policy action. It's incredibly simple. And everybody got it. Again, we had extraordinary media with very little resources on our part to achieve that. I've been able, you don't need me to tell you any of this, you know all that. That's the argument behind that particular case. And that's the sort of information that is in the document and which we convey to people when we meet with them. I've had asks, and we have delivered on probably, I don't know now, 30 or 40 meetings with backbenchers and state members of Parliament. That's a really important level to be influencing, and we often don't reach them terribly well. We've also met with ministers, of course. This year we're working on the detail of implementation. So we have a paper coming out on active travel to school, which was the physical activity working group's #1 priority. We have extraordinary figures of physical inactivity in children and young people, and more extraordinary figures on their weight. And we all hear everybody saying the next generation is going to live shorter lives than their parents. That's a disgrace. But when you actually look at the data on how many children are overweight, you just think, oh my God, what have we done? How could we have done it so quickly? I mean, I don't try and remember the figures because I just keep choking on them. But in here, where is it? Physical activity. Children 5 to 11 not meeting physical activity recommendations, 70.8%. And we've set a stretch target of 63.7%, that's still 2/3. And children, young people who are physically inactive, where are they? 91.5%. That's people 12 to 17. That's when we think they're out playing netball and doing all sorts of things. But only 10% of them are, 9% of them. So this was our first policy implementation piece of work, again with the working group, but also with more experienced implementation experts, including someone from South Australia who leads a statewide strategy to get children active to and from school. We're calling it break the drive and drop syndrome. And what we're asking for is that all schools over a 5-year period be assisted by their local governments with state and federal support to have drop-off points around the quadrant around the school, at least 1 kilometre away. And those lollipop people can be out there, and there'll be more of them. So this is a piece of work that's being developed very carefully with a lot of people who've tried to do it, are doing it in small places, and it will be a national strategy, and so on. So we're doing others. We're working on junk food marketing to children. Lots of people have worked on this. All we're doing is coming up with a simple policy formula. So it's distilling the work of many others into something that's tight and simple. So that's our national policy work. One of the other things we were asked to do by VU was to set up a living laboratory in the West, a research relationship in the West. We now have that in place with the City of Brimbank. We've used a much broader database to develop a profile of the City of Brimbank. It's in the West. Sunshine is its core LGA, but it goes from Braybrook to Taylor's Lakes. It's a long, thin LGA. It was once 3. It's intensely multicultural. Every language that's in Victoria is in that local government area. It has significant socio-economic disadvantage. Our objective there is to, over a 20-year period, have a tightly connected to this work, local area, place-based approach to bringing about change in an intensely socio-economically disadvantaged community. So that in 3 to 5 years, we hope we'll be able to say to Commonwealth governments, as well as other state governments, don't fluff around with pilots and trials. This is working here, just take it and spread it. That's the hope. And as you can see, it's a unique opportunity. We still don't have much funding support. We're still on a knife edge of survival. But the intention is to be, over time, as effective in bringing experts together and pushing policy out in a way that's digestible and implementable, just as the King's Fund has done and the Commonwealth Fund has done in the United States. So that's an ambition. But way to go yet.